Sara McArthur's illness started at the age of 45 years when she developed what she called a very small tremor in my left hand, and this was when she was using a computer. A year later, she said my walking was off. It felt like my navigational system was off. It seemed harder for me to reach my destination. And just 3 years later, she started experiencing falls and was toppling off even stationary bikes. She observed that she could not maintain her balance when she turned suddenly or if she had to avoid stepping on something. She explained that it was like my legs could not keep up with my brain. She also began to veer when she walked, becoming unable to walk in a straight line. As her condition progressed, McArthur's speech also became affected. Sara McArthur was just beginning a complex journey that would eventually lead to a diagnosis of ataxia, the name she gave her memoir. Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast, which will be discussing the most inconvenient movement disorder known as ataxia. The literal meaning of ataxia is irregularity, confusion, or disorderliness, and it's also described as an absence of order. But strictly speaking, in the medical sense, it refers to poor coordination that is not caused by loss of muscle strength or sensation. According to Clockgether and Paulson, the practice to use ataxia to designate a disease goes back to the mid-19th century when Duchenne coined the term locomotor ataxia for tabes dorsalis, that is a form of syphilis. As a clinical sign or symptom, ataxia is a non-specific term, as impaired coordination can result from an unimaginable array of disorders. McArthur's doctors initially diagnosed her with essential tremor, and even when they eventually considered ataxia, they did this very tentatively. After visiting a series of neurologists and movement disorder specialists, McArthur was eventually diagnosed with degenerative cerebellar ataxia, and this was 8 years after her symptoms began. The signs that were picked up on examination to support the diagnosis of ataxia were impaired balance, unsteadiness on walking, slurred or drunken speech, called dysarthria, inaccuracy when reaching for an object, called dysmetria, jerky eye movements, called nystagmus, and impairment of smooth eye movements when tracking objects. Recognizing that a person is suffering from ataxia is, however, only half the problem solved. The more difficult part is to identify the cause of ataxia. And this is no easy feat, as the list of causes are literally limitless. In McArthur's case, the cause was thought to be genetic because her grandmother had suffered with a similar illness which began when she was 55 years old. McArthur was therefore tested for the frequent genetic causes of ataxia. She had genetic tests for spinocerebellar ataxia or SCA types 1, 2, 3, 6, 7, 8, 10, and 17. She was also tested for Friedreich's ataxia and the condition called DRPLA, the tongue-twisting acronym for dentatorubropallidoluysian atrophy. All these tests were frustratingly negative in McArthur's case. And the reason for this is not far-fetched. There are just too many genetic causes of ataxia to check for one by one. The genetic ataxias are classified into autosomal dominant ones, such as the spinocerebellar ataxias, the episodic ataxias, and DRPLA. Then there are the autosomal recessive ones, such as Friedreich's ataxia, ataxia with vitamin E deficiency, and ataxia telangiectasia. And then there are the X-linked types, such as Fragile X tremor ataxia syndrome, or FXTAS. McArthur was also tested for many genetic disorders that may have ataxia as part of their presentation, and these included Wilson's disease and mitochondrial disorders. And to ensure no stone was left unturned, McArthur was also tested for the acquired causes of ataxia, and these included autoimmune and metabolic blood tests such as anti-GAD antibody and celiac disease. McArthur also had an MRI scan of the brain, which helps to identify cerebellar ataxia by showing shrinkage or atrophy of the cerebellum, which is at the back of the brain. And to complete the cycle of investigations, she also had spinal fluid analysis and electromyogram or EMG, an electrical test of muscles. Without a reversible cause, McArthur's ataxia expectedly progressed. She lamented this, saying, "I was losing the ability to be able to put one foot in front of the other and move in capital letters. I was walking very jerky and stiff, and my falls were increasing. My fear of falls was intensifying. I had no warning that I was going to fall. I would just fall hard, so fast I had no time to break my fall." She eventually required a cane and then a wheelchair. A person who did get a confirmed diagnosis of spinocerebellar ataxia is Dana Lorene Creighton. Writing in her memoir titled A Family Disease, a Memoir of Multi-Generational Ataxia, Creighton described how the autosomal dominant condition affected her wider family. She wrote of how she inherited the disease from her mother, whose 4 siblings also suffered from the disease, having inherited it themselves from their father. Many of her mother's siblings were mistakenly diagnosed as having Friedreich's ataxia. She explained that this was because the genetic marker linked to this mutation wasn't discovered until 1996. Creighton was 34 years old when she had the genetic test that confirmed that she carried the mutation for spinocerebellar ataxia type 2, also called SCAR2. It is a sad feature of the disease that 2 of her siblings also developed ataxia. Although she did not express overt features of ataxia until she was about 40 years old, looking back, however, she could find early signs of the disease when she played college ball. And this was when she increasingly struggled to catch the ball, and she spent more time on the bench than on the field. Later, she described how incoordination disrupted her ability to take blood from patients at work. At other jobs she worked, she said she was frequently called out for not performing up to expectations. Creighton described a peculiar genetic feature of SCAR2, which is the link between the length of the genetic mutation and how early and how severely the disease manifests. This feature is called genetic anticipation. She wrote that in SCAR2, repeats above 100 are likely to result in symptoms in infancy, and just above 35 can result in later onset. She illustrated this with her family's case, where a brother with 22 repeats was not affected, but she with 43 repeats and another brother with 44 repeats were affected. Another person who wrote of the impact of SCAR2 on her life is Patricia Birdsong Hamilton. Writing in her memoir titled My 35 Years with Ataxia, Hamilton described how she inherited the disease through her grandfather and then her father. She also explored the 25 separate symptoms that affected her and how the disease led to early retirement. Some of these symptoms were missing her serve when playing tennis, walking into door frames, suddenly sliding off chairs when sitting down, misdialing telephone numbers, frequently losing balance, clumsiness, and slurred speech. She also described problems with carrying cups of tea, with wearing her clothes, turning over in bed, taking a shower, picking up coins, doing buttons, and even standing and paying the grocery bill at the supermarket. It is important to point out that the number of genetic mutations that cause spinocerebellar ataxia has been rapidly expanding, and there are now about 50 different forms. We now turn to the autosomal recessive ataxias, and the focus must be on the most frequent form of this, the one named after Nikolaus Friedreich. It is no coincidence that the term Friedreich's ataxia has already cropped up 3 times so far in this podcast. Nikolaus Friedreich was born in 1825 in Würzburg, Germany, to a medical family. his great-grandfather being a surgeon and physician to Würzburg royalty. Friedreich's mentors also included such great doctors as Rudolf Virchow, who he succeeded as Professor Extraordinarius of Pathological Anatomy and Physiology in Würzburg. Friedreich then moved to Heidelberg, and this was where in 1863 he published his first seminal neuropathological work on the disease that will come to bear his name. And this was titled On the Degenerative Atrophy of the Spinal Posterior Columns. He followed this up in 1876 with a second, larger supplementary and complete work with which he completely established the nosological clinical existence of Friedreich's ataxia. This is a quotation. Let's illustrate the lived example of Friedreich's ataxia with the memoir narrated by Alicia Weston titled A Girl on Wheels, My Story of Living Through Youth with Friedreich's Ataxia. Chronicling her experience, Weston wrote that their parents first noticed that she and her sister both had problems with balance and hand coordination. Some of the difficulties she had was poor handwriting and a tendency to drop objects, the results of hand incoordination. And her balance difficulty led to frequent falls. She wrote that an injury every week became normal for me, explaining that she fell so frequently that she would often have an injury on one body part or another, and she sustained several scars under her chin. Weston also had several investigations to diagnose the cause of her incoordination, including a head scan, but she said the results all came back the same, with nothing wrong. The sisters were eventually tested for Friedreich's ataxia, and the genetic mutation was also present in distant family members who had been diagnosed with the disease. Her parents unfortunately both carried the gene. This had to be the case as Friedreich's ataxia is transmitted in a genetic recessive way, and two parents need to have the gene to pass it on to their children. On learning that she tested positive, she said, "I felt numb. Nothing can truly prepare you to hear something like that." She referred to it as a diagnosis my whole family would need to help me bear for the rest of my life. As she was only 11 years old at the time, she explained that my family had a harder time watching me get progressively sicker than I had in experiencing it. She added that it would take many years to understand how dramatically it would change my life in so many different ways. Physical therapy was the only treatment available at the time for Weston and her sister. She progressed through a series of manual and electrical wheelchairs, and she eventually also needed a scooter. Friedreich's ataxia is a disease that also affects other organ systems beyond the nervous system. Weston illustrated this when she narrated her experience of seeing a cardiologist and having an electrocardiogram every year, explaining that Friedreich's ataxia is complicated by cardiomyopathy in about 90% of cases. Other wider problems in Friedreich's ataxia beyond cardiomyopathy include deafness, nystagmus or jerky eye movements, diabetes, a foot deformity called pes cavus, and urinary problems. Unfortunately, not all people with cerebellar ataxia get a definite diagnosis, and this was the case with Deborah Levi. Writing in her memoir titled Finding Level Ground, My Journey with Cerebellar Ataxia, she wrote of how her mobility declined in her 30s and she started falling inexplicably. By her 40s, she said she had lost many motor abilities and couldn't jump, skip, hop, or walk a straight line. And to get into a car, she said, I grabbed the steering wheel for added support. She also developed the habit of looking for flatter and flatter surfaces to walk on, but this did not stop her from frequently falling. To steady her balance, she resorted to holding on to walls, counters, furniture, trees, bushes, or even her children's hands. She also required ramps or stairs with two-sided banisters to assist. By the age of 55 years, she required a cane, something she had deferred for reasons of vanity. She changed her mind after sustaining a fractured wrist following a very bad fall. She shortly retired from her teaching career, explaining that she had been absent too many days to constant illness, and that it had become difficult to walk across the schoolyard or make my way to the office. She said even the lunchroom was off limits. To seek a diagnosis, she scheduled an MRI brain scan, which she said showed significant loss in the cerebellum. She wrote that as my cerebellum shrinks, my body moves to a slower song. Perish the turns, twirls, twist, perish the pivot. My fast turns of past years fade as days and nights fall and dust settles, covers my weary bones. No longer adjusted to speed, I move to gradual beats, tuned instead to relaxed rhythm. To explore ataxia further, I will be speaking to Professor Susan Perlman, the author of the book Evaluation and Management of Ataxic Disorders, in the next episode of this podcast. Thank you for watching or listening to the podcast. If you found it enlightening, why not subscribe to the Apple, Spotify, or the YouTube channels of the podcast to ensure you do not miss the next episode. And whilst waiting for the next episode, why not check out my book titled Surfing the Brain, or my website called Neuro Checklist. Thank you very much for your time.